So myself, Rajendra Sahoo, I'm a consultant pain specialist at Kim's Hospital, Bhubaneswar, welcoming you all on behalf of ISSP Bhubaneswar City Branch. So the city branch was formed just before the last conference that we held here at Bhubaneswar, and recently we have decided to conduct regular academic events in the form of webinars, CMEs, and also a state chapter meeting. I have taken over as the secretary of the city branch, and let me introduce our society executive committee team. So, president is Dr. Ritesh Rai. Most of you know him very well. Uh, he's pretty well-known figure in the regional anesthesia circuit. Dr. Ritesh Rai is a consultant head of the department at Care Hospital, Bhubaneswar. Vice President is Dr. Sovan Muratha. He is quite known face. He was the previous secretary and has been practicing in Bhubaneswar for last 15 years. And then I have taken over as the secretary here. Treasurer is Dr. Dr. Gaurav Agrawal. He's again practicing at the Care Hospital Bhubaneswar. Again, his core area of interest is regional anesthesia, ultrasound guided blocks, and they're doing very well with Dr. Ritesh Rai. And the EC members, the executive committee members includes Dr. Pritam Mahanti, Dr. Sunaina Mapatra, Dr. Subhamayananda, and Dr. Devasish Jena. So it's a small team, and we have some 15-20 active participants in the team also. So we have Dr. Smriti Hota, who is from Sambalpur, practicing pain there quite actively for last few years, and there are a few other members as well. So this is the first meeting. So the topics are going to be really, really good actually, not basically focused on the intervention. This is basically based on the actual stuff we see that on day-to-day basis. The topics that will be carefully chosen and the faculty will be chosen who are experts in the field, both clinical learning, teaching, experience, the research, everything will be taken care of. And in the going forward, we have some big names coming up from around the globe also. So, so few things I would request all of you to keep their video camera on and keep themselves muted. And if they have any questions, I think they should have, they can type in the chat box. So we can take all those questions at the end also. Okay, I request sincerely all of you to just mute themselves so that there is no unnecessary noise in between. So we have some 89 participants so far, which is very good. So let me introduce our speaker for the evening. So we have Dr. Ravi Padmanabhan. So he had shared a very short CV. He's a very senior radiologist, interventional radiologist, practicing at Singapore as well as Australia. So he did his radiology training from Australia, and he frequently visit there for his diagnostic radiology as well as interventional pain management in Australia. So currently, he is based at Singapore. So he is the director of Radiology Education Asia. That is a kind of a teaching platform. He offers, conducts regularly courses for all those radiologists for MSK reading for all those joints, spine, uh, shoulder, hip, knees, ankles, everything he does it, and he conducts courses also at different places in Asia, Middle East, Asian countries also. So teaching radiologist, pain and sports medicine physician to assess MSK and spine MRI and CT online as well as on site also. He's a visiting senior consultant radiologist different places in Australia, and he's a consultant to Fujifilm Singapore for imaging training. So with this background, can I request our speaker, Dr. Ravi Padmanabhan, to take over and present his uh, lecture. So this is basically about the uh, spine MRI for the pain physicians, not only pain physicians, but anybody who is practicing pain, like neurologists, like radiologists, PMR specialists, rheumatologists, spine specialists, and even other intervention radiologists also. We should know the MRI, not rely on the reporting from a radiologist. Okay, so all of us before jumping into any intervention, that is basic motor. I look like what is T2, T1, what are the star images, which one to look for, foraminal, canal, central protrusion, lateral recess, the sacroiliitis, all those things. We should be able to interpret ourselves, than solely rely on the reports. The reports can be flawed also. As we know the pathology, we suspect something, we should be able to look for where to look for the facet arthropathy, is there a facet cyst, the sacroiliitis, all those things. Without wasting much time, over to you, Dr. Ravi Padmanabhan. Thank you for joining us.
Thank you so much, Dr. Rajendra, and also to the committee for the invitation to speak. For some of you I have met, but most on this call I would not have met. Dr. Rajendra and I met a few years ago. I actually came and did a course with him on ultrasound because he is just so amazing at ultrasound guided intervention. And that's not something that I had been doing detailed things in. So I came to learn, and that was a fantastic learning experience in Bhubaneswar. So today we are going to look at imaging of the spine, lumbar spine, and sacroiliac joint. And this is aimed at pain physicians. This is not for radiologists. So the thing with this is that when you are looking at a scan, you're not looking at it the same way as a radiologist to look at. We are looking at it as a diagnostic thing. But for you, you need to be able to just see, have a quick look through, and then find the abnormality, and then decide whether that's what you want to treat or not. So let me just share now. Just give me a moment. Just give me a moment. Just give me this one. Okay, so you can see my screen.
And yeah, I can see.
Yeah, okay. And as Dr. Rajendra said, so I do a lot of spine imaging and also spine intervention. And a lot of the cases we get are not from scans that we've actually reported ourselves. So I have two options. I can just look at the report that someone else has done, or I can actually look at the scan myself. And I would never put a needle into someone without actually being able to look at the scan myself. I just would not rely on another report. It's not that all the reports are wrong. It's just that there's enough times where you can find things which have not been reported, or it's been over-reported or under-reported, or whatever it is. So I think if you're putting needles into people, you really need to be able to look at a scan for yourself and decide whether you need to, whether it's correct to put that needle in the right place or not. So the aim here is really just to take you through how to do that. And we're going to look at a few things. We're going to look at sequences. This is what people who are not radiologists find incredibly difficult. They get very confused with it. We're going to make it very simple. And then we're going to look at the various causes that you can see on a scan that cause nerve root compression or facet pain. So these are things that you're commonly going to put needles in for. And then we're going to have a look at SI joint degeneration and also sacroiliitis. Okay, so sequences, this is difficult for most people, but you can keep it really as simple as this. In a lumbar spine, all you are going to do, you're going to do 3 sequences. You're going to do a T2, a T1, and a stir, which I'll come to in a moment. So there are various ways to work out whether it's a T1 or a T2 sequence. Often there will be numbers in the top left-hand or right-hand corner of the image that you can read that and you can work out what sort of sequence it is. But far easier is just look at the CSF. Okay, so on a T2, CSF is bright. On a T1, CSF is dark. That's it. So just by doing that, you can work out whether it's T1 or T2. You don't need to know any physics at all. And so these are the axial scans. So we've got T2, so CSF is bright, CSF dark on T1. And you can see that fat, this is the posterior epidural fat here, is bright on both. So you can't use fat to differentiate. You have to use fluid. We also will do another sequence called a T2 fat sat or a stir sequence. Depends on the machine and who's doing it and stuff. You can do either. And the aim of this is to remove that fat signal, and anything that's fluid becomes very, very bright. So in this case, we've got abnormal bone marrow signal here in the sacrum. And the benefit of this is that it just strikes you, right? You don't need to search for it. It's just straight away you can see that it's too bright. You can see that the pedicle here is too bright. Sequence that you must get from your imaging center. Okay, so what sequences should you get? So you should really be getting 5 sequences. What will happen is that some centers will do less because they want to save time, so that you can get more patients in through the day. Now that's for you is not a good thing. So what you should really be insisting is that you should be getting a sagittal T1. They tend to leave out. They tend to leave this axial T1 out, and you really need to have that. And then you get a T2 Facet or a stir, and that can be sagittal or coronal. We tend to do coronals, and I'll explain to you why that is. Actually, I can show you now. So when you do a coronal stir, what happens is that you also get the sacroiliac joints, and you get the sacrum. So instead of asking for a separate sacral imaging and the patient gets charged more, get a coronal stir, T2 Facet, and uveitis or infection, you will be able to see on the single sequence. Okay, so let's have a very quick look at
Dr. Ravi, sorry to
something, what
interrupt.
these
I
sequences
know
are.
your voice is a little low. Can you just
Yeah.
speak a little louder? There is some people cannot hear it completely. Hello.
Yeah. Okay, can you see the dikes? Yeah, can you see the
Yeah,
dicoms there?
yeah, we can hear you now. For a moment, it got stopped
Oh,
actually. Yeah, we can see it
okay.
now, but we can't hear you.
Okay, so okay, all right. So here we have sagittal T2, sagittal T1. This is the stir sequence. Sorry, this is running so I think because of the screen sharing, it's actually running very slow. Okay, here we go. So it just takes a bit of time. So this is T2, this is the stir sequence. And you can see that when you look at the stir sequence, straight away you get abnormal signal here at the end plates. So these are Modic type changes. We're not going to particularly go into that, but the aim of this is to really just to show you the benefit of using a stir sequence is that you can see it on the T2. Here it is. I mean, there's some white signal there, but it's much more obvious here on the stir sequence. So that's why you have to use a stir sequence or a T2 fat sac sequence in your lumbar spine. Okay, so the next bit I think people, non-radiologists I see having trouble with is that they actually don't know where to start. They don't have a structure. So you'll see people putting, if you've got cut films, they'll put films up, they'll just sort of randomly be looking at things. And if you do that, you're not going to be able to get to a diagnosis. So you need to have a structure, and that's what we're going to go through in a moment. So I generally onto the axial scans. There's one thing that is incredibly important in spine, particularly lumbar spine, is symmetry. When you look at an axial scan, this is the patient's right. So the right side should be exactly the same as the left side. There should not be any asymmetry. So if you see asymmetry, there's something wrong, and you need to be able to explain it. So this is something that I'll show you in a moment as well, but symmetry is very, very important. So let's look at a case here. So let's maybe start with the MRI. Okay, so as I said, whether you're looking at it on a PAX viewer or you've got films that you're looking at, I would start by looking at the T2, start at the sagittal in the midline. So what this tells you is that this gives you an indication of whether there's any major disc herniation. zoom this up. Okay, so it gives you an idea whether there's any major disc herniation. You then start to scroll out or look out towards the sides, so to go out laterally, and then you get into the foramina. So here are the pedicles. We'll go into more detail on these in a moment, but the method to use, you start in the midline, look for discs, and then scroll out, move out, and then find the foramen and look for any foraminal stenosis. So on the sagittal scan, if you do these two things, you'll actually find a lot of abnormalities. You don't need to even look at the axial sometimes, especially for foraminal narrowing. So foraminal narrowing predominantly will use these sagittal scans. And then on the axial images, we want to look at the central canal. So let's start that again. So let's look at the central canal. These are the foramina. We look out at the foramina, and then we'll also look at the facet joints. Facet joints you can see on sagittals as well. This is the facet joint out here, but it's actually easier to assess on the axials. You can look at both, but it's easier to look on the axials. So I would look at the facet joints on the axial scans. So on the axial scans, you're looking at the central canal, you're looking at the foramen, and then you're also looking out here. This is the extraforaminal or far lateral space where you can also get discs. So on the axial, you need to look at for far lateral or extraforaminal discs on axials, because if you look at where the scans are done, you will see that the last sagittal image doesn't quite go far enough into that far lateral space. It actually just covers the foramen. So if you don't look at these axial scans, you'll miss lateral disc herniations. For CT, it's the same thing. I won't go specifically into CT just for the interest of time. And one other thing before we start to sort of get into the individual areas is this concept of traversing versus that should be exiting, traversing versus exiting nerve roots. So this is only at the lumbar level. It's not at the cervical or thoracic level, because cervical and thoracic, the nerves basically come out and go, they come out of the cord and they go straight out into the foramen. So at the C5 level, the nerve will exit the cord and exit C5 at that same level. Whereas because we have the chorda equina in the lumbar region, lumbar spine, you'll have nerve roots that go all the way down the canal and then eventually get out into the sacrum. So they're the traversing nerve roots. So we have this concept of exiting nerve roots and traversing nerve roots. So if we look at this L4-5 level, the nerve root that is coming out of the foramen at L4-5 is the L4 nerve roots. So that's the exiting nerve root. And the nerve root that is going in the canal and then goes down and exits at L5 is the traversing nerve root. So if we do a slice through this level, through this L4-5 level, we will have an exiting L4 nerve root, and we will have a traversing L5 nerve root. Okay, now the importance of this is that depending on where your disc herniation is, at L4-5, you can either be compressing the L4 nerve root, so if it's a lateral or a foraminal disc, or if it's a central or paracentral disc, you'll be compressing the traversing nerve root and you'll get L5 symptoms. Okay, so that's the importance of differentiating these traversing and exiting nerve roots. So if we look at this image here, axial scan, I'm not sure what level this may be 3, so let's say it's 3-4. We've got the L3 nerve root coming out, so that's in the foramen. This is the exiting nerve root. The next nerve root that's lining up to come out is the L4 nerve root, so this is the traversing L4 nerve root. Now, we'll talk about synovial cysts in a moment, but here we have a synovial cyst that's projecting into the canal, affecting the traversing nerve root. It can't affect the exiting nerve root because it's not in the foramen. So if this is L4-5, this is going to be the L5 nerve root that is compressed. On this one, we've got a cyst that's in the it's in the foramen. So again, if we say this is L4-5, this is now going to be compressing the L4 nerve root, which is exiting, but the traversing L5 nerve root is normal. Okay, so let's have a look at this. So to sort out traversing and exiting nerve roots, you need the axial scans. We're going to call there is some transitional anatomy here, but let's call this L4-5. So if I start at the top of L4, we can see that the L4 nerve root is now coming out of the foramen, and this is now the traversing L5 nerve root. So a foraminal disc or anything that foramen is going to compress L4, anything that's coming into the canal will compress L5. And this is the traverse and the nerve roots like this, it's really MR that you're going to use for the CT can tell you about foraminal, it can show you the foraminal nerve. It doesn't show you the nerves within the canal, but you can infer that if you know the anatomy on because you know that the traversing nerve root is here, even on CT, even if you can't see that nerve root, you know that it's going to be the L5 nerve root that's compressed. Okay, so let's go into the individual things that you're going to look for. And disc herniations, depending on where they are. So if you look at this, so we have the canal here. If you have a central disc herniation, so something that's in the midline, or a paracentral, so paracentral to the side of midline, what's going to be involved are the traversing nerve roots. If you have a foraminal disc herniation, so the disc comes out here, it's going to be the exiting nerve root, and similarly if there's a lateral or extraforaminal disc herniation. And I come back to this because this really is your biggest friend. Okay, so symmetry is so important. It's fine if you've got a big disc. No one's going to miss a big disc. Sorry, a big disc. But you will miss a small, subtle disc if you don't look for symmetry. Okay, so let's say this is L5S1. Canal, we have a right paracentral disc protrusion. You can see the exiting, so you can see the traversing nerve root on the other side, and that looks fine. So first off, what you're going to notice is that there's asymmetry. Okay? We've got fat here, we don't have fat on this side, so you have to explain it. So the explanation is that there's a disc, and then you know from the anatomy that the traversing nerve root lies in here. This is the subarticular recess, and the traversing nerve root is there, and the traversing nerve root is what's compressed. Foramen. So discs in the foramen, we're going to look at them on the sagittal scans, and we're going to look for disc material that's occupying the foraminal space. It's better to see this on the actual diagrams, which you'll see in a moment. And these are the lateral discs. And the best way to see these is on the T1 weighted scans, which is why you must get T1 weighted scans, axial scans from the company that's doing your imaging.
Dr. Ravi got frozen for a moment. Can't hear you. The slide is not also moving. Yeah, he's joining back actually, no? So there are some technical issues, that unfortunately keeps happening with all those Zoom meetings, networks. Sometimes the slide not moving forward, voice becoming low also, in spite of having a good network also. So he's joining back. I just had a word with him. Please have some patience.
Okay, sorry about that. I think for some reason the internet seems to have dropped out. Hopefully you can hear me now. Dr. Rajendra, I'm not sure whether you can just let me know if you can hear me or not.
Yes, sir. You are audible.
Okay. Oh, audible. Okay, great. So just give me a moment. I'm just going to start this up again. Okay, let's start that again. So I'm not sure where I dropped off. So I was basically just saying about discs and lateral discs and how the symmetry is so important. So 3 different types of lateral discs, each smaller than the other, but the only thing that's really going to help you, especially with these small ones, is the difference in symmetry between them. And on CT, it's even harder. Right? So CT, we don't have as much contrast resolution. So if we follow this out, we've got the nerve roots coming out here, symmetric. symmetric, but not here. We've got something that's asymmetric, and then we go to the next slice, we have this asymmetric nodule out here compared to that. So especially, I mean, for CT and MR, symmetry is incredibly important, especially for lateral discs. So let's have a look at a couple of discs, how we actually assess them. So if we just start with normal, this is a young patient. So if you look at the disc spaces, the discs are actually pretty well maintained, and the signal is also bright. So normal disc will have a lot of bright signal in it. There's a lot of water in it. And as you age, as it becomes more degenerate, it desiccates. So then the signal reduces. So it becomes darker and darker, and also the disc height reduces in size. If we, let me go back to 8. So start, and what I'm going to do is when I go through it is actually go through that process that I would do when I'm reporting, so that it just sort of should become second nature to you when you're looking at an image, that this is what you do. So he starts in the midline. There's no disc herniations here, but when I get to L, there's a bit of a disc bulge. Now we can characterize that in various ways, but we'll just stick with disc bulge at the moment. So then when we look at the axial scans, here's the disc. It's a broad-based disc bulge. And again here. And then what your job is then to see, well, what's it doing to the nerve? So the disc on its own, okay, may cause back pain, but if you're looking for radiculopathy, you need to see what it's doing to the nerve. So here we have the nerve root. Let's follow that from the top again. So here's that traversing. So here's the exiting L4, traversing L5. This is the subarticular, getting into that sort of subarticular and lateral recess. And here's the disc, which is contacting that traversing L5 nerve root. And you can also see that there's quite significant asymmetry. So the thing that should be striking your eyes is that the asymmetry is there, and then we have this disc that is touching that left L5 nerve root. What about the subarticular and lateral recess? So this is a common area to get nerve root compression. It's also a common area to miss seeing it, especially if it's a small disc, but this is a fairly large disc. Let's go here. So you start with your sagittal scans. We've got mild disc bulges. We've got a lot of disc desiccation. You can see that the discs are quite extrusion. So it's cut away from the end plate. So this is an extruded disc. And then we need to really sort of look at the axials to try and work out what it's doing. So now if we look at the axial scans, here's the L5 nerve roots coming out. This is the traversing S1 nerve roots. And as we come further down, large left paracentral disc extrusion, which has compressed that traversing left S1 nerve root. So you're expecting that the patient should have S1 nerve root symptoms. Let's look at it. So let's look at a foraminal disc. So as I said, the foraminal, to assess the foramen, you can assess the foramen on sagittal and axial, but I find that the sagittals are actually very, very useful. And let me bring that across. Okay, so start with the sagittal, so midline. We've got a disc herniation here, keep going out. And then you can see that we have the nerve root in the foramen at the level above. That looks fine. But here's the disc that's compressing that exiting nerve root. Now, if you try and find that on the axial scans, this is the disc here. So again, asymmetry, exiting, but you get a much better sense of what that disc is doing when you look at it on the sagittal scans. That it's compressing that exiting nerve root and it's pushing it up. So for foraminal, so so the sequence of looking at is that you look at the sagittals, you're looking at then at the axials for anything within the canal itself. And then on the sagittal scans, you go out to the edges and look for any foraminal extension of that disc. And these are some examples of lateral discs. And I think what I'd like you to do is, if you can, is I'm going to scroll through on these axial scans. And then you, for yourself, just try and figure out where this asymmetry is. So I'll tell you that there are two lateral discs here, which you can't see on the sagittal scans. Okay, so asymmetry. So here's the lateral disc. And here's that second one, much smaller, again with the asymmetry. Now, if you look at where the scans are being taken, this one you can, they have gone out wide enough, but I think you'd have trouble if you find that on the sagittal scans. So much easier on the axial images. Okay, so I might, just for the sake of time, we'll probably run overtime here, which I don't want to do. So let's look at the ligamentum flavum. So ligamentum flavum is going to, if you have ligamentum flavum hypertrophy, it's going to result in either canal stenosis or foraminal narrowing, but more commonly canal stenosis. The normal ligamentum flavum is this sort of low signal line. It's quite fibrous, so there's not much fluid in it, so it's not very bright. So it's a fairly thin line that you'll see on the, and it's best on the axial scans. This is a markedly thickened ligamentum flavum. So this is going to be contributing to canal stenosis. So the things that are going to contribute to canal stenosis are going to be disc herniation. Second one is ligamentum flavum hypertrophy. And on CT, we normally see a thin amount of ligamentum flavum, but this is quite thickened. This also happens to have some calcification, which we don't see on MR, but we only see it on CT. But you can see the asymmetry here. So this one is actually relatively thin, but we've got marked thickening of that patient's right side. Show you a couple of cases. Let's just go to, we'll show you what to look for. So ligamentum flavum hypertrophy, it's hard in the canal to actually see it on the sagittal scans. You can, and this because this patient has got such severe thickening, you can see it on sagittals, but it's much easier on the axial. So let's look at what that looks like. So thickened ligament flavum here, it's very low signal, quite thick. Keep going further down. And then we've got really marked thickening of that ligamentum flavum. And that's really the predominant cause of the canal stenosis here, the severe canal stenosis, secondary to ligamentum flavum hypertrophy. Now, the thing is, if you're doing an epidural, you want to know that this ligamentum flavum is thick as this. We do epidurals under CT. So it's fairly easy for us to work that out, but under fluoroscopy, I'm not quite sure how you would actually know that. So this is something you should be able to work, to see for yourself on a CT or an MRI. Okay, what about facet degeneration? So facet degeneration, we want to know about for two reasons. One is that it can be a source of pain. Secondly, it can also result in foraminal narrowing and nerve root compression. So a normal facet on a sagittal scan, so this is the pars interarticularis here, inferior articular process, superior articular process, and here's the facet joint in between. So the normal facet on CT, you should be having a nice sharp cortical margin. It's smooth, it's sharp, it's well-defined. Let's go to an abnormal one. If you look at an abnormal facet, so irregular, that sort of nice, bright, differentiated white line is gone. We've got subcortical cyst formation, and there's also joint space narrowing. And you can get gas within the joint as well. So this is, if you look at a plain X-ray of a hip or a knee, what you're looking for degenerative changes, joint space narrowing, subcortical sclerosis, subcortical geode formation. It's exactly what you see here, an ossified formation. And on MRI, what we're looking for again is that sort of thin black line, low signal line. Sorry, I'd gone to, let me go back to that. Well, this is the ligamentum flavum. On the facet joint, again, we have a nice, well-defined joint. It's quite a small joint, so you won't see much fluid in it. You may or may not see fluid in it. Nice, well-defined. There's no ossified formation. Facet degeneration is much easier on CT than it is on MR, which we'll see in a moment. Okay, so what changes when you have facet degeneration? So here's a normal facet, patient's right. We have some mild facet degenerative changes here. So we have some sclerosis, joint space is narrowed, joint margins are not quite as sharp. So we've got some mild degenerative change. In this patient, it's a bit more severe. So we've got moderate change. So we've got ossified formation, narrowing of the joint space. And again, joint space is pretty well preserved on that right side, but there is some ossified formation. And then when you get really severe facet degeneration, you get this sort of bony hypertrophy. So you can see that the facet joint, the facets have actually widened. They become thicker, they become bigger. And we've got joint space narrowings, cortical sclerosis, subcortical cysts, and big ossified formation. So these are the ones that are going to, when you have this ossified formation, that's what's going to cause the narrowing either in the subarticular recess or cause narrowing in the foramen. And on MR, it's much harder on MR, especially the mild ones. Yeah, mild ones, it's quite subjective. It's easier when you've got some bony hypertrophy. So here, the facets just look a bit too big. Ossifieds just looks a bit irregular. And here, it's actually very severe. But MR is much more difficult to look for facet degenerative change. And if you look at this image here, it's the same patient. We've got really marked ossified formation. But if you look at this, I mean, it's there. The ossifieds are here, but it's much harder to see it on MR. Okay, what about trying to figure out whether a facet joint is symptomatic or not? So when you do imaging, you often see multi-levels where there's facet abnormalities. And on imaging, it's actually incredibly hard. We're not good at working out which is the symptomatic facet joint. You can use things like effusions, especially if they're asymmetric, which can point you towards maybe that's a symptomatic facet. Nuclear medicine is better for this. The thing that on MR that can help is if you see bone marrow edema. So this is actually cervical spine. We've got a cervical facet joint. We've got lots of fluid in the joint, but we've also have bone marrow edema. So this is a stir sequence, and we've got bright bone marrow edema on either side. So once you see that, it's almost certain that they're going to be symptomatic from that. But that's not that common to see. It's fairly uncommon to see bone marrow edema. Okay, let's look just at a couple of changes here. Maybe let's look at 4. So this is, let's look at a CT. Let's go back to okay, so hopefully everyone's happy that this is facet degenerative change. On the patient's left, we've got joint space narrowing. There's actually gas within that joint. You can see how low signal that is compared to the other side. Facet hypertrophy. And then you can see also that just the whole thing looks a little bit bigger. You know, there's actually bony hypertrophy, which is fairly common in severe facet degenerative change. And let's look at 6, just on MRI, what that looks like. Yeah, in this patient, I'm trying to find even a normal facet. There's no normal facet. So one of the things that's very useful in spinal imaging is to go, if you're not sure, go to one of the higher levels and have a look at the facet joints or whatever it is up there, because the internal reference of something normal is very helpful. So, but this one, you've got facet degenerative changes at all levels. But let's find, if you look at this, ligamentum flavum, sorry, window that, ligamentum flavum is thickened. Joint spaces are not that well seen, just looks a bit irregular. Let's go down a bit further. And here you can see just there's a whole lot of bone in here. Much bigger than it should be, small cysts. But as I said, on CT, this is absolutely straightforward. For a non-radiologist, I mean, for a radiologist, this is very straightforward that this is facet hypertrophy. But for non-radiologists, it may not be that straightforward. So CT is much better for you to assess facet changes. Okay, just one brief thing about facets is that they can produce cysts or synovial cysts. They come from the facet joint and they extend out. So they can extend out into the canal, or they can extend out into the foramen. You can also get ones that go into the posterior paraspinal space, but they're not really relevant to us because they don't cause any pain. But the ones that are symptomatic are the ones that go into the canal or go into the foramen. And really what you're looking for, there are multiple appearances for facet cyst. This is the standard sort of simple cyst, which is bright on T2 because it's filled with fluid. Again, asymmetry, we've got ligamentum flavum, facet hypertrophy here, but on this side, we have a cystic structure that lies adjacent to the facet joint. These don't tend to track, like if you have a meniscus, like a meniscal cyst, they can track a long way from the meniscus. These facet cysts tend to stay around the facet itself. So generally what you'll see is that they sort of lie adjacent. You may not see a neck to it, but they'll be lying adjacent to the facet joint. So let's quickly look at this. So some facet degenerative change. Again, bilateral facet degenerative changes here. There's a little bit of canal narrowing. You can see that the facets have grown into the canal. And as you come down further, then you get this structure. Again, we've got facet degenerative change, and then you've got the cystic structure, which is lying adjacent to the facet joint. It's projecting into the canal, into the epidural space. And so then we know from the anatomy we've just discussed, just bring this up, that here's the traversing nerve, here's the traversing L5 nerve root. That's it there. And as you come down, L5 is going out. This is now going to be S1. So here's where S1 is being compressed. So S1 on the right side, S1 is somewhere in here on the left side, which is compressed by the nerve. Oh, sorry, by the cyst. So for facet cysts, look for a cystic structure. So it's low, it's high signal on T2, low signal on T1. This is the T1 weighted scan here. And you can see that high signal T2, low signal on T1. So that's fluid. So this is, and it's lying adjacent to the facet joint. So this is a facet synovial cyst. Okay, so we actually, if anyone's interested, we actually have two videos on this. They're quite extensive on CT and MR appearances of facet cysts. So there's a QR code there. Okay, let's go to the foramen. So we've discussed the canal, we've discussed discs involving the canal, we've discussed the ligamentum flavum, facets, and then foraminal stenosis. So foraminal stenosis is very important to look for. And as I said, the best way to look for it is actually look at it on the sagittal scans. And the anatomy that we're looking for is that, so find the pedicle, and underneath the pedicle is where the foramen is. And in the middle of that foramen is the nerve root. So this is the so-called keyhole appearance, where it's like a keyhole. You've got the nerve root in the middle, and there should be plenty of fat around it. So if you look at this image here, we've got potential compression of this nerve, either from disc or osteophyte coming from the posterior end plate, or coming from the facet joint, which can compress, narrow and compress that nerve root. let me show you, before we go to normal, let me show you what can happen. So we've got three possibilities of foraminal narrowing. So just because there's foraminal narrowing doesn't mean that there's nerve root compression. So again, you've got to keep in mind that when we scan, the patient is lying down. You have no idea what happens here once they stand up. So maybe that foramen narrows more and this gets compressed. But if you look at this image here, we've got the pedicle nerve root. There's no fat on top of it. There's a disc at the bottom of it. So there is foraminal narrowing here, but the nerve root is normal in shape. It's just that we've lost fat around it. So there's narrowing of the foramen. The second option we have is that, again, we've lost fat around this nerve root, but the disc is now touching the nerve. Here, the disc is not touching the nerve. There's fat space. So we've got contact with that nerve. And in this one, we've got actual compression. So we've got three possibilities. There's either foraminal narrowing without contact, foraminal narrowing with contact, or foraminal narrowing with compression. Osteophytes are a common cause of foraminal narrowing. And
Dr. Ravi, sorry to interrupt. Can you just explain that last slide one more time about that compression without touching the nerve? Yeah, I know.
I'll
How
show
to
you
look
that.
for that compression in the foraminal one, the last slide.
So this one?
No, the previous one. So the foraminal narrowing, no compression, no touching, it's touching, and then compression. Yeah, this one, this
Okay.
one.
Yeah, okay. All right, so let's go back. Normal foramen, right? So nerve root here, surrounded by fat. So no question of any compression or narrowing here. So now we've got a disc that's gone into the foramen. We've lost this fat at the superior margin of that nerve root, but we still have fat. There's a fat plane between disc and nerve. And the nerve itself is normal in shape. So the nerve should be a nice round shape, round or oval. So there's no compression here. There's no contact, nothing. But again, you've got to keep in mind that this is done with the patient lying down. So when they stand up, it's quite possible that that foramen narrows a little bit and this disc then touches the nerve. So we don't know that. So you still need to use your clinical judgment of whether this is, if say this looks like an L5. So if they've got L5 symptoms and they've got this, it's possible that when they're standing up, it's going to reproduce their symptoms. Second bit here is that now we've lost the fat plane between the disc and the nerve. So the disc is now in contact with the nerve. If you look at the shape of the nerve is still sort of oval shape. So is this symptomatic? No, we can't tell. On imaging, we can't tell. Cases where the disc is touching nerve, patient hasn't got any symptoms. And in the worst cases where you've got disc and then you really don't have anything that looks like a normal nerve here, the nerve's completely crisp. I'll show you this a bit better on the DACOMs. So in your report, you should be getting back describing what's happening here, that the disc, there's narrowing. So, how would I report this? I'd just say that there's foraminal narrowing secondary to a foraminal disc, which lies adjacent to, but does not compress the exiting left L5 nerve root. In this one, I'd say it's lying adjacent to and is in contact with the exiting left L5 nerve root. And here I'd say that it's in the foramen and compressing the exiting left L5 nerve root. So it's just a matter of severity. But it's imaging severity, and how that translates clinically is up to you. Okay, so most commonly what we're going to see is not just one thing. We're going to see multiple things. We see discs, we'll see osteophytes, see ligamentum flavum, hypertrophy, and you'll have a combination of these things that cause the foraminal stenosis. So let me show you, should be able to see normal here as well. So just to save some time. So as I said, when we're looking at the foramen, we want to really look at the sagittal scan. So let's start on the midline. Let me bring that one across. So then you can see what level we're at. Okay, so we're going towards the patient's right. Here's the nerve root, fat around it. Okay, so let's look at this level up here. You can see that's got that keyhole appearance. Here's the nerve root. So this is a normal foramen. Okay, hopefully everyone is happy with that this is a normal foramen. But if you look at the foramen below, let's do that same thing again. Foramen is very narrowed. So again, compare those two. Go to the next one. Here's the nerve root. Very severe narrowing of that left foramen. So the nerve root's not yet compressed. There's a lot of contact with disc and ligamentum flavum hypertrophy, but it's not compressed, just very severe narrowing. Let's look at the other side. So we've got a couple of options here. So look at this level. Coming out, here's the nerve. So there's some narrowing. Here's the disc. Fat plane is present between that nerve and the disc, and it goes out. So there's some left side of foraminal narrowing, but no compression of the nerve root. Let's look at the level below. Again, we've got foraminal narrowing, mostly now here from ligamentum flavum hypertrophy, was just pushing from posteriorly. Again, but no nerve root compression. Let's look at the level below that. So L4-5 now. Here's the L4 nerve root coming out. And you can see that there is severe narrowing. This is the nerve root sitting up here. And this is all disc. So you don't see any plane between the disc and the nerve. The nerve is severely compressed and pushed up against the pedicle. Okay, but again, just look for symmetry. Symmetry is so important. So if you look at this, there's plenty of fat. There's no fat here. So if there's no fat, you have to explain why there is no fat. And it's because something is filling that space. You don't just, fat just doesn't disappear. Look at the level before. We have a disc. And this is, again, one of those examples that we showed before, is that you've lost the fat plane. It's in contact with the exiting left L5 nerve root, but there's no compression. So can you see these on the axial scans? Well, you probably can, but it's not that great. Okay, so here's that L4-5, and we're saying that there's severe canal stenosis with foraminal stenosis with nerve root compression. But you really you've got trouble seeing it, because the nerve is sitting right at the top here, and all of this is disc down here, but you just can't see it. So for the foramina, don't look at the axials, look at the sagittal scans.
Yeah, perfect.
Okay, maybe I might, how are we going for time? Can you tell me how much longer I've got, and then I can...
Yeah, I think you can continue. We're all enjoying it.
Yeah,
We're getting
I'm
some new
also aware-
information.
Yeah, it's a Saturday night. I'm sure nobody wants to really be sitting here listening to this, but so I'm not going to sort of have everyone sort of staying till late. We're going to fit a reasonable time. So maybe I'll just quickly show you the CT, because you do see a lot of CTs. Maybe you see more than that NMR. So let's have a look at this. Okay, so just look at this soft tissue window here. And so again, it's good if you are actually looking at the scan yourself and you try and find something. So there is foraminal stenosis in this, which that's what we're talking about. So look at these foramina and you figure out which one is bad. Which one are you going to put a needle into, or which one are you going to treat? Okay, so if you look at, this is 4, this is 5, this is S1, look at L5. Severe narrowing. Okay, and that you can't see that nerve root. Nerve roots are harder to see on CT anyway, but if you look at this one, here's the keyhole appearance, nerve root in the middle, fat around the sides. There's no fat, space is severely narrowed. It's just all sort of soft tissue. So there's severe compression of that exiting, I think it's the left L5 nerve root within the foramen. Okay, so then we sort of circle back to canal stenosis. I didn't start with canal stenosis because we actually needed to discuss all these other causes of canal stenosis before we actually could discuss this properly. So when we look at the canal, on MR, we will see the thecal sac, which is the bright fluid-filled area. These are all nerve roots, the cauda equina. And then we have the epidural space around it. On CT, it's much harder. Okay, so because we just don't have enough resolution. So this is the thecal sac in here. Don't really see nerve roots. A little bit of posterior epidural fat. So fat is low signal on CT. So this is but if you look at the size of the canal, it's normal. Now, when we teach in India, the people often ask about canal sizes, like measuring the size. It's not something that I do at all, not even routinely. It's because the size of a canal is going to vary according to the shape. So the shape of someone my size is going to be completely different to someone who's bigger than me or someone who's smaller than me. So generally what we do is just actually have an internal measurement of what is normal, what looks normal. There will be normal areas, so you compare with normal and see, and then it's a subjective thing. It's a mild, moderate, or severe. Generally, you wouldn't give measurements. And so if you look at this is a normal canal. Okay. I'd say that there's some mild narrowing here because thecal sac's a little bit sort of compressed, but not terribly much. But here, this is moderate. We don't have that. So again, use your internal references. So if you compare that with that, there's a significant difference, right? So I say there's moderate central canal stenosis here. And in this one, where we've got this very large disc, we've got severe thecal sac compression, even though the canal's probably not that reduced. It's maybe moderately reduced if you look at the whole size of the canal. This disc is really severely compressing the thecal sac. So you should be seeing these individual nerve roots. Here, because the thecal sac is severely compressed, they're all pushed together, and then you don't see them as individual nerve roots. So let's look at let's look at MR. Okay, so again, starting with these sagittal scans, you're seeing that there are multiple levels of disc herniations here. Now, assessing canal stenosis on a sagittal scan is not a good idea. You really can't assess it properly. So, but what you do know is that, okay, I've got disc, so I'm going to have some level of canal stenosis. So it's telling you that I need to be looking out for canal stenosis. So then when we look at these scans, let's start at L3-4. Broad-based disc bulge. Again, now we're going to go through the things we've just discussed. Ligamentum flavum hypertrophy. Facets also are a bit big. So it's a combination of a broad-based disc bulge, ligamentum flavum hypertrophy, and facet hypertrophy. And we've got sort of mild to moderate central canal stenosis.